Welcome back, dear viewers, after this short break. And again, we have with us Dr. Fatimah Alansari. Welcome back to DocTalk.
Thank you for having me again.
Well, it's our pleasure, especially now we're talking and discussing a very important topic about cardiac rehabilitation. So now we're going to talk about the treatment. What are the main stages? Let's talk about the stages of cardiac rehabilitation. We know it's, okay, post-surgery.
Mm-hmm.
Okay, then what?
Well, it's post-surgery and also post-cardiac event with patients who have been diagnosed with a cardiac disease or patients who had angioplasty. Now, the stages or the phases, it depends usually, it depends on the guidelines. You have the American guidelines, the British, Australian, but usually it's between 3 to 4 phases. Phase 1 is the inpatient at the hospital. Phase 2 is the outpatient phase, but it's kind of like a waiting phase between the phase 1 and phase 3, which is the outpatient clinical phase when the patient comes to the hospital to do their cardiac rehabilitation program. What the difference between that and phase 2? Phase 2 is, yes, they are at home, but they have been prescribed to them a very gentle, light exercise program to do at home. It's similar almost to the same exercises that they would be doing at the hospital. And then it's a follow-up phase, phase 2 also. And then they're just, as I said before, they're waiting for their appointment to be included in the program. And the program itself, it's the most, it's the longest time, which is phase 3, which is around 2 to 3 months, according to the patient, 2 to 3 times a week. Some patients, sometimes they don't have, so we modify and be flexible with their times. And they would come, for instance, once a week. And we monitor them and we build up their physical fitness. And then afterwards, they are discharged from that phase, the outpatient phase of the program, and continue, which is usually basically, it's a maintenance phase. Because just because you do a cardiac rehabilitation program does not mean that you end there. The patient has to still continue to be physically active and do their exercises, and then follow up every 6 months, once a year, with the cardiac rehab specialist.
Okay, now we talked about the stages. Is there like an early interference or late interference in that rehabilitation or enforcement to, you said outpatients, but is there any like rehabilitation for inpatients, for patients inside the hospital?
Yes, definitely there is inside, starting from the ICU even, which is very known for physical therapists to be early mobilizing the patients in the ICU or the CCU, or now the ICU or the wards. Now the ICU is basically for patients who have done major heart surgeries, and then the CCU is sometimes it could be a follow-up for these patients who had in the past these surgeries or had a heart attack, or just freshly diagnosed with a cardiac disease. And then the wards are for the patients who are less complicated. But they definitely also, all of them, all these locations throughout the hospital, we look into these cardiac patients, and according to what they need in terms of mobilization, in terms of exercise, we deliver those exercises to these patients.
Okay, my next question, how does the patient start stage 1 inside the hospital? As you said, we're still in the hospital. Okay, you talked about ICU and in wards. But let's say he's in the ward. And there's the patient comes in the routines, and the doctor or the therapist comes within the routine. But it is in scheduled or in daily?
No, it's usually daily. We do want to benefit the patients, since the patient is at the hospital.
The patient is in location, so there is no distance and there's no...
Definitely. So we look into the patient every day. Patients who have, for instance, weak muscles, problems with their joints, problems with their heart rate, problems with their breathing, problems with any sort of other problems, we start to give them gentle exercises, bed exercises. It includes all movements of the upper and lower extremities, which is the arms and the legs. And then we slowly encourage the patient to get out of the bed. And we do have exercises while the patient is sitting on the edge of the bed, or for instance, sitting on the chair. And then we start also monitoring the patient's walking around the bed, walking in the room. And then we progress to taking the patient out in the ward, in the corridor for a longer distance, and including also, it includes a little bit of aerobic exercises, very gentle, very gentle mobilization exercises.
Now, Dr. Fatimah, let's talk about the time, the fixed time for the program or the stage, or does it depend on the case?
The fixed time for...
The fixed, yeah, for each stage. You said stage 3 maybe take 3 months?
Yes.
Yeah. But let's talk about
the session itself, you mean?
The session itself.
Well, the session, it varies also. It takes probably 45 minutes to an hour. I've had sometimes some patients up to an hour and a half.
Okay.
Now, these patients, because they are cardiac patients, so they need a lot of time, for instance, to warm up before the exercise. Sometimes some patients... because I don't do the traditional 5 minutes warm up. I need to sometimes make sure that my patient is safe. So sometimes the patient might need 10 minutes, 15 minutes of warm up.
Yeah.
And then also these patients, they need a lot of time to rest because of having their breathing problems.
Yes.
Or for instance, the blood pressure goes high or the heart rate goes high. So these patients, they need a lot of time. So the session takes from 45 minutes to an hour.
So it's like monitoring also, it's more like monitoring than exercise. Because,
definitely.
Yeah, because you are afraid that maybe one wrong exercise that will lead to a catastrophe.
Definitely,
let's say.
Definitely. Hopefully not.
Hopefully not.
Yeah, but definitely. And then you would factor in also patients who are the geriatric patients, the older age patients. They are very slow. They probably are in the wheelchair.
And so fragile,
very fragile. They need assistance getting in and out. So sometimes, I love to take my time with my patients, and I never rush the patients. And then younger patients, of course, they're sometimes depending on the patient, but they would take 45 minutes just to be safe with them, even if they do their exercise session quicker than any other patient or ones who are athletic. But also I have to make sure to take my time and make them rest.
Okay. Yeah. Well, that concludes our segment. We're gonna look into a short report and then we're gonna continue with Dr. Fatimah Alansari. So please stay tuned. Welcome back, dear viewers, after this short report. And Dr. Fatimah will tell us about the psychological and social importance and how do we raise the awareness socially, and what is the psychological side of these rehabilitation effects, and how do we need to overcome them. So what is the effect of anxiety and depression, especially here? People think they lost their life.
Yes.
They're not going to go back to normal life or activities. How can we combat anxiety and depression?
Well, anxiety and depression, actually, a lot of cardiac patients, sometimes people think I exaggerate when I tell them. I've seen it firsthand with my patients way back in 2007. When I was doing my master's degree program, because my master's degree program was looking into the patient's mental health after they are discharged from the hospital.
Yes.
And I was actually, which was very helpful for me, because that is where I found out that patients are affected by a cardiac incident, whether it's surgery, any kind of procedure, or the disease of having to find out that they have this problem. So I've had patients that would not even talk. They are that depressed. And then sometimes the medication affects their mental health. So it makes patients depressed. So also I need to look into what sort of medication they're taking, and what they are doing exactly. I really try to dig deeper with these patients and ask them a lot of questions. Usually the first visits with my patients also take an hour, because I really sit down and talk about everything, even their nutrition, even though if I'm not a nutritionist, but I like to ask the patient, and the patients feel like I'm listening to them and I'm caring. And that is part of the cardiac rehabilitation program. That is part of my assessment. That is part of my evaluation to these patients, because the mental health affects physical activity.
Yes.
Physical, your exercise, your food intake. It will probably make you eat unhealthy food.
Some people stuff that emotional gap with cakes, with desserts.
Definitely.
And that will reflect on their heart health.
Definitely, and then go back to smoking, for instance, and vice versa. Because they are smoking or because they are not physically active, they feel depressed. So I encourage patients to maintain their exercises and their physical activity, because it is a fact. It really helps and improves their mood, gives them back and gains back their confidence, their self-esteem. And as I said, those who have problems with their weight, they will see by time. I always encourage patients, never rush with your health.
Yes.
Especially those who have weight problems. Never rush with trying to lose weight. Losing weight does not necessarily mean that you will have a healthier heart. I've had patients who dropped 20 kilos, and after the 20 kilos, they had a heart problem or they had a heart attack. So you need, again, back to the self-monitoring, back to maintaining, back to being continuous with your healthy habits. Just because you reach a goal does not mean you neglect other parts of your healthy habits. So you gotta keep everything. And sometimes, as I said, the family history. The family history plays a big role in this.
Yes.
So the family history, I'm sorry to say, but it does chase these patients.
Well, there are a lot of patients and family members, they deliberately neglect and deny that they have a family history. I don't know where this kind of fear comes from, but if you ask any patient, no, I don't have any family history.
Yes.
Well, your mother might be diabetic, your father maybe have blood pressure. You need to mention these things.
Definitely, yes.
Yeah, family history here in Kuwait, most of patients neglect it.
Yes.
Yeah. For me, for instance, if I go for let's say I have an appointment with a doctor, or a doctor asks me, do you have a family history? I tell him so and so and so and so from my mother's side, and so from my father's side.
Definitely.
So maybe he will give me something that will contradict with my, let's say, alleged family history.
Yes, yes.
Yeah.
Because that's why, because fortunately, like you, because you're conscious, you're aware, you're educated.
Yes.
And we need to do the same thing. We need, when I ask my patients, a lot of these patients also, when they think their mothers or fathers died at a young age, they would think because they had, it was just something like a natural cause.
Yeah, out of the blue. They
out of the blue. So I asked them in details, okay, what about your uncles? What about your cousins? And also, as I said, the age. So we look into all these problems, because unfortunately, I've had even patients who were marathon runners, but because they had diabetes, and they had diabetes in their family, they also are stubborn. They would think, I will not be like my mother. I will not be like my siblings.
Yes.
I will run a marathon.
I will break the circle or the curse.
Exactly. And I will eat healthy, but I will not take my medication.
Yeah.
So again, they took out from the equation one thing, and then they come and they are in their 30s, and they come to the clinic, and then we find out that they're having problems.
Yeah.
So when you know if the family has any sort of these comorbidities or these chronic illnesses, if the doctor has prescribed to you a medication, even if you're very active and you maintain your exercise program and you eat healthy, you still have to take your medication, and vice versa. If you are taking your medication, you still have to exercise.
Yeah. So it's something that completes the other.
Definitely.
Okay. now from psychological point of view, do you have sharing circles, like more like moral support or emotional support groups for this kind of, in that kind of rehabilitation, or each patient have to have their own privacy and limits?
Well, it's a cultural thing in Kuwait. I've had patients that love support groups, and I've had patients that are against support. I think we need to tackle that culture, that mindset of having, when I was doing my PhD, I had a small number of patients that were okay with having group therapy, with talking about their emotions, and they also exchange a lot of experience. They learn about the symptoms, and they learn that, oh, you are different, she is different, he was different. So it's a game changer, as they say. But when I was in the UK, I would have like 30 patients. When I was doing my training at the hospital, I would have 30 patients doing group support therapies, and everybody took their turn and talked, and we would have a certain time, and they would come again, and they would attend even their exercises. But so it's just we need to change the culture by time. So because I believe in support group, it really helps the patients.
Well, it also helps the patients to go back in normal life, to socialize, to get engaged with their own community after being feared not to be included or to be accepted again in the community.
And exercise as well. And so when they come to the clinic, they become friends with one another.
They create their own community.
Exactly, and they encourage each other with the exercises. And as I said, sometimes when you're right there and then, you learn, you pick up details. And for instance, you would hear, oh, this patient had a problem with her nutrition, or this patient doesn't know where to buy, for instance, a blood pressure monitor. So they would start that conversation. Builds up and starts, and they would learn from each other. And of course, with the supervision of us, the therapists, the specialists, to help them and guide them.
Your supervision.
Definitely, yes.
Well, that concludes our segment. Then we're going to jump into myth and facts. So I have a lot of myths.
Great.
So please, my dear viewers, join me after this break. Welcome back, dear viewers. Now it's my favorite segment, Myth and Fact, with Dr. Fatimah Alansari. So my first myth: after a heart attack, the patient must avoid all social activities.
No, completely false. On the contrary, they need to socialize, they need to do, they need to exercise, and exercise while socializing, and socialize while exercising. So it's completely necessary for them, for their well-being, for their mental health.
Well, that's important to socialize.
Definitely.
Because sometimes we have a patient, no, don't visit him, don't visit her. They need to rest. They always emphasize on the rest.
No, on contrary. But don't eat too much. And watch your weight and take your medication.
That's the key. So the next myth: the patient cannot fast or change diet.
No, also completely false. Patients can fast. Patients can do diets if they want certain diets, if they prefer some diets, as long as they talk to their doctors and talk to their nutritionists.
Is there a certain kind of food or nutrients that is more important during the rehabilitation stages?
It depends on the patient. If they have some problems with their nutrition, or if the nutritionist and the doctor found out problems with their in their blood test, but mainly to eat healthy, mainly. And then in cardiac rehab, the nutritionists usually they do educational sessions. They do provide educational sessions, and then us also, the cardiologist, the physical therapist, we also educate the patients on nutrition, healthy nutrition. Of course, it will be more generic and general information, but the nutritionist would specify more things that are according to the patient's tailored nutrition program.
Well, that's important. Diet, as you said, diet, exercise, and social. Definitely. We are completing the circle.
Yes.
Okay. My next myth is: the patient, light smoking does not affect the heart of the patient.
No, smoking does affect the patient's heart, and especially if you find out that you had a heart problem, you should immediately
cut smoking.
Cut smoking. A lot of
not gradually, immediately.
No, immediately, immediately. A lot of my patients would compare other friends or family members who are smoking, and sometimes that they are older but don't have a cardiac problem. So I always tell them, never compare, never tell me or tell your doctor why so-and-so is smoking but is healthy. Or
it's more like a childish behavior, jealousy, it's involved
definitely
in here.
And again, it's back to the education and the awareness. I have to tell the patients, you are different. You have a heart disease. Your friend or your relative does not have a heart disease.
Maybe they have something else.
Maybe they have something else. So just because that patient is continuing to smoke does not mean you have to continue to smoke also. So we need to educate patients that everybody is different. And then sometimes genetically, not also just the family history, knowing that you will eventually have a heart problem, but genetically, sometimes your body is different. Your arteries are different.
Exactly.
So sometimes they're a little bit more sensitive in clogging, or they will be more narrow. So genetically, you have to be also conscious about that and not compare yourself with other people.
Well, that's important, especially comparison here plays it. They want to be normal again.
Yes.
But still they compare themselves.
Yes.
And getting denial involved. And I'm okay. I passed the heart attack. I'm healthy. I can walk. Khalas, I can go back to smoking.
Yes.
So it doesn't play like that.
Yes, definitely.
Okay. The myth is the patient can never drive again after surgery.
No, the patient can drive, but it depends at the time, and it depends on the surgery. But usually the doctors or us, the physical therapist, we advise the patients to go back to driving after a month or a month and a half.
Okay.
Just to make sure that the suture or the incision site is well.
The upper body physical activity sometimes irritates some movements.
Yes, definitely. So driving, sometimes you're having, I always tell my patients, even if you think you're driving, Doctora, just a little bit, I'm just going to go to the co-op. It's right there by my house. I tell them never drive after your surgery, because sometimes when just leaving your house, backing up the car, sometimes somebody passes by, or a car or a cat or anybody, and then you would probably need to push on the brakes very suddenly or do a sudden movement if somebody's rushing in the neighborhood. So even if you tell me if it's a short distance, I do not advise.
We do not jeopardize that.
Yes, so they need to wait, and after they follow up with their cardiac surgeon and make sure that everything is fine. And also in terms of exercises, we don't give patients a lot of exercises that stretch for the incision site, or a lot of arm raising over the head with the exercises. And then we always advise for them to wear a special vest, kind of like a cardiac vest, to hold and heal the scar and the wound. Yes.
Well, that drives me to the end of this segment. So we're gonna jump into the final part. So please stay tuned. Welcome back, dear viewers, to the final segment of today with Dr. Fatimah Alansari. Now, let's talk about going back to life. You said there are stages for rehabilitation.
Yes.
The final stage is number 3 or 4, or maybe it depends on the patient.
Actually, sorry, it depends on the guidelines.
And the guidelines. Yes. You said there is a
the American guidelines and the British.
Yes. After these stages are done, when can we go back to act normal, go back to life?
Well, I think it's a very valid question, when to return back to life. I think from stage 1, the patient should not worry about returning back to life, to normal life. That's why it's very important that we support the patients emotionally, psychologically, and educate these patients from very early on. Now, in terms of let's say, for instance, work. If they want to return back to work, they need to be also to get the clearance from their doctors, and it depends on their work, how or their lifestyle. Where do they live? How are they, driving back and forth to work? Are they using elevators? If they do have elevators where they live, or stairs, for instance. So a lot of these things we need to look into. And also, of course, their exercises, their physical activity. I give these patients a lot of tips and strategies on how to be physically active at their homes to slowly prepare themselves for society, for going out. And of course, with a lot of monitoring and follow-up. Also about their intimate relationships with their spouses, because of course this is also a lot of the intimacy with the spouses. It raises up the heart rate. So patients do have a lot of these questions. So we also guide them slowly and monitor. Again, they could have an exercise stress test. They could have a cardiopulmonary exercise stress test. And look into their intensity of their exercises. So anything that looks into the intensity of the exercises, it can help us define the patient's going back to their normal life. But again, it depends whether they need to build it up, especially if they're athletic, or if they could just at least maintain their physical activity. And then we are always there. We always encourage patients that we are always there to have that chat and talk about their physical endurance and physical fitness.
Okay, we talked about the patient. Now let's talk about the community in general. Let's talk about awareness. We said that the community, even now with this massive advancement that we are living in, the social and norms are still there. Let's say the omens. Okay, he's a heart patient, let him rest. These negative thoughts about, or let's say backward or backdated thoughts about cardiac diseases. How can we raise awareness? Now we have a young rising generations, and we have also young doctors, we have young doctors and caretakers. How can we elevate that kind of awareness?
Start young. I think we should start young, start in schools, with the children. Talk about, cardiac diseases. They could have visits at the hospital, or doctors can go to these schools and talk about heart diseases. They could also, and then even the patients who come to the clinic. As I said earlier, I sit down with them for a long time, and I try to investigate what they are doing in terms of their physical activity. What are they eating? What medication they're taking? If they are also monitoring their blood pressure, their heart rate. So I also ask them to write a diary about their blood pressure, their heart rate, their oxygen, because the oximeter that is advised to patients, if they can buy it at home, to look into their oxygen levels. So all these, plus the educational sessions. Cardiac rehab programs actually provide educational sessions. So you would have patients, you would invite the patients to come and talk about the benefits of taking their medicines, the benefits of exercise, the benefits of eating healthy. And also, so that raises their awareness, and then the word of mouth gets spread between these patients, with their relatives, with their family members, with their friends, about how it is important to look after our health, our hearts.
Thank you, Dr. Fatimah Alansari, for joining us in DocTalk. It was lovely to have you, and especially address this matter and raise awareness among our audience and people here in Kuwait.
Thank you so much for having me. I had a lovely time.
Well, it's our pleasure.
Thank you.
Well, my dear viewers, also thank you for joining us, and enjoy your day.